Okay. So what I'm going to do now is just share my screen, and I'm sure you've seen this, but this is our program for the week. So we've got 1 hour talk in the morning, obviously before you guys all start rushing around doing everything, and then 2 over lunchtime. So today we're doing bones and renal. On Tuesday we've got endocrine and cardiac. Wednesday's lungs, imaging infection, and GI and nuclear medicine, if I can get this thing to roll, which it sometimes does. Thursday we'll be looking at pediatric nuclear medicine, and then oncology. And Friday morning we'll have just a bit of an introduction to therapy, mainly benign thyroid disease, and then some cases. As you know, the main part of therapy is done in the next year's course, which I do hope won't be over Zoom, but these things are not up to me. So that's basically what we plan to do. And as I said, hopefully we'll get the thing recorded and find some Dropbox or something so that it's available via the UP website. So any questions or comments at all? Okay, so the general rules of a Zoom thing is if we're on our sort of lecture bit, it'd be kind enough to mute yourself, not because I don't want to hear what you say, but because there can be other sounds around, cars, people, telephones that could disturb other people. If you've got any questions, you can put it in the chat box, or you can use my WhatsApp number and I'll look at that intermittently. If I think is a really important question, I might just answer it immediately. If not, I'll do them at the end. And again, you can just ask questions at the end. But we have found with previous talks, the chat box seems to work quite well. So what I'm going to do now is get started, if that's okay. So what I do is, so we're going to start off as we traditionally do with looking at bones. So I'm going to talk a little bit about obviously bisphosphonates, and then we're going to, in this morning's session, really just concentrate on benign bone disease with a bit on SpecCT and SpecCT. So many agents have been used to image bones. The first one was strontium-90, which does have a gamma emission. It's not a very good one. Likewise, people have used fluorine-18. Both of these were used, but images had very poor quality. And using the kind of scanners available in the 50s, you had about a 40mm resolution. So you could just about define the skull and spine and pelvis and a bit of long bones. But for example, you never saw ribs.
Prof, we can't see your screen.
Ah, okay. I don't know why that is. I am sharing screen. I'll try to work out why that's not happening. Could you see the previous share screen?
No, we were seeing you the whole time.
Okay. Why is that not happening? I'm not very good at Zoom is my problem. I'll just see if I can put this thing to work.
Okay, we see your screen now.
I think you just have to do it multiple times so it works. Now what we're going to try and do is go to, so that I've got large script. So can you still see it?
Yes, now we see it. Thank you so much.
I don't know. It's okay. Right. Start again. That's a bit on bisphosphonates. This is the other agents that we use. This is where we got to. So in 1963, Manny Subbaraman invented the technetium generator. And in 1968, the first bisphosphonates became available. Now, I know for you guys, this is ancient history, but I was actually alive then, though I was still a school child. And we think when we did a survey with all the big societies, we think there's about 1 million bone scintigraphies that occur each year. So it's still a pretty popular study. So what we use now are the diphosphonates, that's methyl diphosphonate or hexyl hydroxy diphosphonates. And how this seems to work, and nobody really knows, to be honest, is it bridges between calcium in the bone matrix. And the uptake appears to be dependent on three main factors: blood flow to deliver the radiopharmaceutical, osteoblast activity, and bone turnover. So where you have increased bone turnover, which may be secondary to a healing or even just an attempt to heal, which is what happens around metastasis, you do seem to get increased deposition of this diphosphonate. They're sometimes called bisphosphonates, and they're two basically the same structures. So the kind of bisphosphonate that's used to treat osteoporosis and the kind of diphosphonate we use are very similar. The bisphosphonates can have more than one phosphorus in, but we tend to just use the smaller molecules. So basically all it is, and this is MDP, what you have is two phosphates connected by some carbon, in this case CH2, but if it's the HDP, it's CHOH. And then you have sodium at either end of the molecule, and then double bond to oxygen. Now, there's the double bond oxygen that binds to the calcium. And where the sodium is, if you use the, you can use a bivalent technetium to attach to where the two sodiums are. And that gives you your structure of your product. But it's also why you need to have an antioxidant in your kit to stop it going to valency 7, then it won't link anymore. So generally, if you have, so there's somebody joining us. Generally, if you have a metabolic bone disease, you tend to have globally increased uptake. I'll show you that later. But for most of the time, we're looking for focal uptake, either infection, tumor, or metastasis. And then there are the overgrowth syndromes such as heterotopic bones, Paget's. These also could be focal. Okay, so just stop for a minute. We also have excretion, uptake and excretion through the renal system. We will see growth plates in children, and you can almost age your child's skeleton by where you see growth plates, but also in some young adults you may see growth plates, particularly in the femur. It may be difficult to see absent uptake. So if you have something like an avascular necrosis, sometimes it can be quite difficult for our eye to see the hole in the normal uptake. And there's reasons for that, which is to do with the way our brain works. There may be abnormal uptake in soft tissue, which have calcium, including infarcts, tumor, and hyperparathyroidism. So this is a normal study, and this is, I'm sure you've seen plenty of these, hopefully you have. And what you can see is a fairly even distribution throughout the skeleton. You'll see the kidneys and the bladder. Now, you will note that the axial bones, the bones in the center of the body, will have much greater uptake than the peripheral bones. And it's not just to do with bone volume, because obviously the femurs is similar volume to the vertebra. But in a normal person, the axial bones have a slightly higher bone turnover than the distal bones. So that's reflected in the distribution of the tracer. So what type of bone scans do we do? Well, we can do spot views where we may have, for example, limited pathology. This is quite often useful in sort of orthopedic type cases. And we may add to that 2 or 3 stage imaging, looking for inflammation. infection or vascular disease. Whole body imaging could be useful. I'll show you that in arthritis. And then we have SpecCT and SpecCT. And what you use really depends a bit on the clinical situation. So it's, this is freezing a bit. So metabolic bone disease. Well, for most patients, the most common metabolic bone disease on earth is osteomalacia. And this is either due to poor diet or due to lack of sunlight or a combination of both. And so areas which have low levels of vitamin D in the diet, and areas that, for example, where I live, where we don't see the sun very much, is much more common. But unfortunately, for most patients, the bone scintigraphy will be normal. Now, what you do see when it is abnormal is you don't get very specific changes, but you can get a very typical pattern in some patients. And in many situations may typically be an elderly patient who may not look after themselves particularly, may be coming in, for example, scanning for breast cancer or prostate cancer or just bone pain. And this is what you may see. So if you remember when we talked about the normal bone scan, that we said that the central bones, the axial skeleton, had the highest uptake. Well, it almost gets reversed in the metabolic bone disease, where you can see much more clearly the peripheral bones. Here you can see that the femur, tibia, and ankles are quite active. And the other thing is the head, particularly the skull, becomes much more active. You may just see the skull and the sternum more clearly, and sometimes not the long bones. That's sort of a semi-pattern. And if you see this, you have to consider the patient may have osteomalacia, hyperparathyroidism, and you also see it in renal bone disease. The other thing, if you note very carefully, is that you don't really see in this patient particularly, which is quite a significant, severe case with hyperparathyroidism, you don't see the kidneys and the bladder, but it's not a metastatic superscan. Some people call this a metabolic superscan. Paget's disease is another form of metabolic bone disease or overgrowth syndrome. The cause is unknown. It's said that the gene is related to if somewhere in your background you have Vikings, but the Vikings got pretty well everywhere. Though they lived in Norway, they got on their boats, they went to America, they went to Africa, they went to Asia. So if it is, it's a fairly common gene. And traditionally what you get is overgrowth of the bones, and the bones start to change shape. They bow. It's like meant to look like a bow. It tends to involve complete bones, as you can see here in the pelvis and the scapula, but sometimes it's not the whole complete bone, as you see in these long bones, such as the femur, but the femur shows very nice bowing here. If it's very focal, particularly maybe it just picks off one or two vertebra, it can look like metastasis. If it's in one bone, it's monostotic, and in other bones, it's polyostotic. What about osteoporosis? Well, we can't really see osteoporosis in the bone scintigraphy. We may see its subsequent fracture, so it may appear like trauma. And classically, you get linear uptake in the spine. You can get cough fractures, particularly in patients maybe with COVID or at the times when we get more upper respiratory tract infections in the winter, and can be a cause of major fractures such as in the pelvis and hips. But we can, in nuclear medicine, use bone densitometry to measure it. So this is a classical patient who has osteoporosis. Now, osteoporosis is a disease of the bone matrix, which can occur in patients over 45. You can't have a 21-year-old with osteoporosis. They can have osteopenia, i.e. a failure to calcify their bone matrix, but they don't have osteoporosis. And classically, you get a low impact fracture. So this is somebody who may just topple over in the street and they break a bone. whilst hopefully you guys, if you topple over in the street, you don't break a bone. You may say, oh, just because they're old, but it's not. It's because they've got osteoporosis. It can cause fractures in thin bones. It can really affect any bone. But the way we tend to see it are things like this, which we've got a bone scan here, again, of a gentleman. And you can see on 5 vertebrae, there's linear uptake across the vertebra. 2 of them are more active than 3. This would suggest that the 2 fractures are more frequently, got more activity, and the other ones are older ones. Tends to settle after around about 18 months, so you can give us some kind of age to the fracture. But sometimes, particularly in very elderly patients, it may not go away. Again, it could be possible to confuse this with bone metastasis, particularly if it only involves, for example, half a vertebra, so you get like a hemifracture. How do we diagnose it? Well, to be honest, the only real way to diagnose it is just to remove the bone and look at it under the microscope. But there is a good correlation between osteoporosis and bone density. However, low bone density only tells us of the risk of osteoporosis and fractures. Now, one of the problems happens if you have lots of osteoporosis and fractures, your bone density can go up because you get collapse of your vertebrae. So you need to be a bit careful how you record things. And it can only really occur after peak bone mass, which is at 35 years, and the patient we would normally consider to be more than 45. That's much, in a way, easier with women because you can also use postmenopausal versus premenopausal. For men who, except for mentally in their head, don't actually get a menopause, then it's more difficult. So people tend to use 45 as the cutoff period. Who should we scan? Well, what we can look at is predictors of osteoporosis, and obviously patients who may have established disease. So if a patient falls over, breaks their hip, the low impact fracture, then we might be worth doing a bone densitometry, and we would tend to do that routinely in many hospitals. The osteoporosis itself is painless, but the consequences are the ones that hurt. So patients won't present to you via their family doctor saying, I've got the symptoms of osteoporosis, because it's only the fractures that have symptoms. So we need to identify particularly at-risk groups, and they would be patients who have medical risks such as on steroids, early menopause, thyroid disease, anticoagulants, and anti-epileptic drugs. Those are the family history, and that for most patients is the strongest risk factor. Low impact fractures, a history of those. So, falls which aren't significant falls, or some people just fracture spontaneously. And symptoms related to osteoporotic collapse in the spine, such as trapped nerves, etc. So we normally measure bone density using an X-ray system on the hip and spine. We can use ultrasound in the heel. Also, you can do forearm with the X-ray system, and we can do a spine with CT and quantitative CT. Straightforward X-rays and waving at them is not good. Now, you may ask, why is this nuclear medicine of these X-rays? It's because it involves measurement with numbers. Originally, it was done with a radioactive source. So DEXA, or DXA, stands for dual X-ray absorptiometry, and uses 2 energies of X-rays and calculates a differential attenuation, which tells you the density of the tissue. And normally use the lumbar spine and the right hip, though obviously there's a problem with the right hip, you can use the left hip. So this is how it sort of works. This is just a cartoon from a journal, and you can see you have a machine that produces the X-rays, and then you have some method by which those X-rays are divided. Either use 2 X-ray sources, or you filter it through a filter that removes X-rays of a certain energy. They pass through the patient, and then you have a detector, and then that's attached to the computer that calculates the density of the tissue. So this is a patient undergoing a DEXA. You'll notice that for the lumbar spine, you elevate the legs so that the lumbar spine is laid flat. Then you put the patient down flat for the hips. And this is what you get. This is from a patient at one of my old hospitals. So you can see, you can measure the different vertebra. And the second vertebra has got a problem. It's got a bit of a collapse. So that's now been removed from the calculation. The advantage is that we can measure the clinically important bones, which are spines and hips. People tend to fracture more, other bones, but it's the spine and hips which are clinically the most important. It's been well established for about 30 years. And if you use the same machine, you get very good reproducibility. If that's not possible, try to use machines from the same manufacturer. And there's a good correlation between the bone density and fracture risk. So it's doing this thing, sometimes it does. So here we have a patient who has had 2 bone densities of their hip, and you can measure over time. Normally you do it about every 2 years, and you can see this patient's dropped their bone density by 3% in 2 years if you look at the numbers here, and that is a significant drop. We shouldn't drop by more than about 0.5%. So this patient is losing bone density quite quickly, and at the moment, though, they're still in the normal range. This is the mean. They will need to be watched very carefully. So how do we measure abnormality? Well, we use something called a T-score, which compares with peak bone. And the peak bone for almost all humans is between 30 and 35. And a T-score between -1 and -2.5 is osteopenia. A T-score of worse than -2.5 is osteoporosis. And we normally think that's a trigger for treatment. However, we know that almost everybody over 65 will be at risk of osteoporosis. And if you measure everybody over 85, they will have osteoporosis on these numbers. So we do not do DEXAs over 85. There's something called the Z-score, which compares you to your same age, and we use this particularly in younger patients. And this tells us if you're at additional risk compared to people of your age. But all of us will have deteriorating bone density with time. So that brings us on to trauma. Now, in any patient, when you look at trauma, we may have to wait a short while before there's a reaction. So in most scans, they will become positive in 1 to 2 days, but in some elderly patients, that may be delayed for 7 days, particularly around hip and pelvis. So the 2 things that's good to look for is increased blood flow and then increased uptake at the site of fracture. Now, this patient has an X-ray of their foot, and they have actually fractured their one of their metatarsals, but the X-ray is completely normal. This is the same patient, and you can see here that there's first of all an arterial phase. It's not always necessary to an arterial phase, but it can help. And you can see in the arterial phase that there is a hot spot down here over covering one of the toes. And you can see much more clearly here. This is the blood pool along this line. You can see uptake that's overlying what is in fact the second metatarsal. And here you can see in the static images, it confirms that this is positive. So positive in all 3 phases, or in the blood pool and static phase, is consistent with the fracture. Other areas that we commonly do is hand and wrist, and particularly it's the carpal bones that can be impossible to see fractures on X-ray. And if they don't get fixed, you can get an avascular necrosis, and this results in a secondary arthritis. And the most common is the scaphoid, and these are nearly always positive, even in elderly patients, by 72 hours. So the patient might fall over, particularly an outstretched hand. They'll get pain in what's called the anatomical snuff box at the base of the thumb. They'll come up to casualty, they can't see anything on the X-ray, they put a scaphoid plaster on, and they get them to come up to nuclear medicine 3 days later. Sometimes the blood pool is not particularly interesting, but this is, the arterial doesn't help so much, but this is the blood pool here, and you can see there's increased uptake over this left scaphoid. And this is the delayed image from the same patient. And you can see, in fact, what they've done is they've broken their scaphoid, and this is the distal end, but they've also fractured their capitate. So they've got 2 fractured bones that need fixing. Sometimes fractures can be more subtle, and these can be related to overuse. And this tends to be related to activity. And most commonly seen in athletes, particularly athletes that have just started maybe going back to practice after a rest period, or in dancers, professional dancers like people who do ballet, and has been also seen in new recruits to the army, where they're forced to run when they haven't run before. And there are two main types. One is stress fractures, and then there's shin splints. And shin splints is probably due to bleeding under the periosteum across in front of the tibia. Stress fractures can occur at any point, but tend to occur primarily in the tibia in sportsmen. And march fractures are a version which tend to occur in the foot. Particularly people who don't buy very good trainers, or decide they're going to suddenly go running, and they get the old trainers out the cupboard and they're not very good condition, so they don't support the foot. Sorry, it does this thing. Every time I let somebody in, it stops the slide. So this is the first one. This was the dynamic, and you can sometimes just see an asymmetry on the side that's affected. And then this is the blood pool and the static images. And the blood pool just generally shows increased uptake around the area because this is a bit inflamed. But when you look at the anterior edge of the tibia in this patient who has shin splints, now they can get a little bit of focal uptake. That's not a stress fracture because it's just on the surface. This is classical shin splints. And the treatment evidently is that you take some pain relief and you're meant to keep running to sort of toughen it up a bit. In any patient, you have to expect the unexpected. This is a patient who had breast cancer, who had pain after a skiing holiday. I was thought to have metastasis, and then we did the bone scan, and there was this hot spot down here. So we asked the patient, did you fall over skiing? They said, oh yes, I fell over to my bottom and it really hurt. So she actually had a coccygeal fracture, and she didn't have any metastasis. This is a fracture it's not a classical march fracture because actually it's in the talus, and this has helped with SpecCT to localize it, but this is what you can see in the patient. So there's a blood pool which just shows low-grade uptake, and this is because the patient's had symptoms for about 2 months. And you can see here in the spot view is very intense uptake, and the SpecCT shows this fracture across the talus. What about arthritis? Well, we have two types of arthritis: inflammatory, rheumatoid, and seronegative arthropathies, and degenerative. And generally, rheumatoid arthritis tends to be symmetrical, tends to involve the metacarpal and proximal phalangeal joints. The seronegative arthritis tend to be asymmetrical, tend to go for the hands and feet and the sacroiliac joints. Interestingly, the hips tend not to be affected by inflammatory arthritis. The knees, unfortunately, are affected. Degenerative disease does tend to affect the hips and the spine. And in the spine, obviously, there's always this great argument, is it due to metastasis or due to degenerative disease? Because the patients in whom we tend to see these issues tend to be elderly. And facet joints are quite common, and until you get very used to seeing them on a planar bone scintigraphy, it's often useful to do SPECT or SpecCT. For local disease, you can use a two-phase bone scan, but it's not good looking at the exoskeleton because there's a lot of activity in the aorta and in the IVC. Most people, however, if you're looking for a pattern of arthritis, will do a whole body study. You can do a whole body blood pool as well as a whole body static image. Remember that once you've injected the tracer, the patient gets the same radiation dose whether or not you scan a hand or the whole patient. However, if you do whole patient imaging, it's always worth scanning the hands and feet separately because you get a much better view of them. The pattern of uptake is very useful, and you can do sacroiliac quantification, but I've never found it particularly useful, particularly in younger people. So here we have a whole body bone scan with an additional view of the hands. This patient doesn't really have anything wrong with them, but they've been complaining of a bit of aches and pains, maybe some mild degenerative changes in the knees, but nothing that looks too spectacular. This is a patient where we have a dual phase, and we can see here very nicely in the hands and feet, we have certain joints. These are the metacarpal proximal phalangeal joints, and here we have, again, sort of not a symmetrical, an asymmetrical pattern of joints being involved in the hands, and this would very classically be a and seronegative arthropathy, such as a psoriatic arthropathy. Degenerative changes, here we can see both hips are affected, and again we see this very commonly in patients who are doing bone scans, and those of you sharp-eyed will say that might be an L5-S1 facet joint as well, and again it can be confused with metastases. They can look remarkably like metastases in some cases. So this leads us on to SpecCT in musculoskeletal diseases. The advantages with SpecCT, it doesn't really change the sensitivity very much, but it does improve your specificity because you can see where there's uptake. But obviously, when we're doing it, we can only do really 1 or 2 fields of view, which limits us to 40 centimeters. So we can't really do the whole patient, though there is now a new gamma camera that's just been launched, which does enable you to do a whole body SpecCT in around about 15 minutes using 12 gamma camera heads, which rotate around the patient. It'll only cost you around about $2 million US. Obviously, SpecCT, the CT part, will have a radiation dose, but this is not particularly high in the peripheral parts of the body. So let's start at the top and get down to the feet. So we're going to do a quick review from top to bottom, looking at reviews of patients in head and necks. And there's not many of them. In fact, this is to do with malignancy, but it does demonstrate the SpecCT can be useful. And this is patients who had cancer of the head and neck and looking for local metastasis. And this paper from Germany suggested that you do get some additional findings with SpecCT. I don't do SpecCT, head and neck very much, so I didn't have the picture. Now we get to the spine. There's a few papers. One of the nicest ones was from the Journal of Nuclear Medicine Technology from Australia. Wagga Wagga is a real place, I did find out. 80 patients with a solitary site of increased uptake, and was correctly identified in only 6% of patients were using planar and 79% with SpecCT. And false negatives were reduced down to just 7 with SpecCT. And this is from their paper. You can see here, typical bone scan we're used to seeing. There's a sort of hotspot in the corner. What is it? And in their image isn't terribly good. You can see that it's in the vertebral body. So this is due to disc degenerative disease. This is a patient from Cambridge, and you can see here in a patient that has a hotspot in the spine. We do a SpecCT, and we can actually see here that there is some osteophyte production, and this is related to, and you can actually see here that there is some damage to the end plate due to degenerative change at this level. Sometimes you find the cause is not what you expect. So this is a hotspot overlying the spine. We do the SpecCT. For some reason, the patient has got urinary contamination halfway up their back. You can imagine how that happened. What about hands? 51 patients with wrist pain was reviewed. 48 lesions seen on planar X-ray. 117 with just straightforward bone scan. 142 with SpecCT, and they said that 37% of patients had their management changed by using SpecCT. And this is one from their paper, and you can see this is very much local uptake here in the middle of the wrist. Whereabouts exactly is that? Well, you could look at a map or an atlas. If you do the SpecCT, you can see, in fact, it's a fractured lunate. I'm not sure how. I'm sure you're all brilliant at your anatomy, but if you're not brilliant like me, it's very useful to have the CT map. This is from Cambridge, and this is a patient. You can see a beautiful scaphoid here with focal uptake in the proximal end due to a scaphoid fracture. So it can be useful, and also useful, for example, this patient that fell over has got a hot spot, which we assumed could be in the scaphoid or the base of the thumb, but when we did the SpecCT, you can see there's some soft tissue swelling, and there's MDP distribution in that soft tissue swelling. So they don't actually have a fracture at all. This is just related to soft tissue trauma. Hips and thighs, mainly we do these around total hip replacements. Metal is a bit of an issue, but there's new CT algorithms which help us deal with these. And just be a little bit careful you don't generate hotspots due to rather overzealous attenuation correction programs. So always look at the non-attenuated corrected images and check it's still there. And bladder activities, there's this thing called count stealing around the hips in iterative reconstruction. So just a bit of care reading the images, but you can get some quite good images. And this is a patient, I find that the coronal views are quite useful. This is a condition called Sappho, which is a condition that involves a fleeting sterile osteomyelitis, arthritis, and acne. And you can see here that there's one of these areas of fleeting osteomyelitis. There's no organisms in this as far as we know. And this is on the lateral aspect of the left femur. So it can be useful. And in this patient with a prosthesis, we can see this is using our CT reconstruction, which is not so affected by metal. The patient had a painful hip after a prosthesis. Around the actual prosthesis head, it's okay, but the distal end, it's there's increased uptake, and this is mechanical stress. And if you look very carefully here, you can see there's a crack in the actual outside border of the femur. So it's resulted in a small fracture, and that needed to be wired to hold it. Knees, a nice bit of work that was done in London, University College Hospital, London. Oh, somebody's drawing red bits over me. I don't think that's me. And this looked at 60 patients, and 9 patients, they looked at whether or not they had infection or arthritis. And they were able to pick up very nicely the number of patients who had significant problems. And SpecCT was correct in 88 patients. I'm not quite sure where these red bits come from. I have to remove them. Anybody can tell me, please do so. This is a knee prosthesis, and this is a very classical problem. Post-knee prosthesis, what happens is you get this uptake where the patella rubs against the inside. The inside of the patella rubs against the metal of the prosthesis, and it begins to wear away the posterior wall of the prosthesis here. And this is a very common cause of pain. And we see this quite a lot. So we do quite a lot of SpecCTs with knee prosthesis. This is one of our patients, and here what we got is, again, a patient who complained of a painful knee. What they've got is they've got an arthritis in the proximal tibial fibula joint. So we finally get to the feet. Feet tend to have a habit of hurting. There's lots of bones in the feet. MR is very popular, but as you know, it's not quite so good at bones. It tends to be a bit non-specific. Planar imaging tends not to be so helpful because all these bones are all overlying each other. So SpecCT can be very useful. And what we call pain generators tend to be things like sesamoid bones. These are additional bones you're not meant to have, particularly in tendons, and ligament insertions or enthesis. So a review was published a couple of years ago of our foot SpecCT, and these were 60 patients with foot pain, and we looked at how we used SpecCT. One study was normal, and the other 59, these are the abnormalities that we saw. The most common ones were stress fractures or degenerative change, but there's a whole mixture of all sorts of different pathologies. And in about half the patients, it changed management. And that included a referral to orthostis for special shoes, fractures with air cast boots, pain clinic referrals. Some of them just had conservative treatment, but at least they knew what was going on. Physios, plasters, steroids, etc., etc. So this is a patient who we knew had a problem because they had previously fractured their ankle and they'd had the screws taken out. They'd fractured about 4 years previously. They still had a bit of screw that broke off left in the femur. And the question is, was that causing the problem? We did the SpecCT, and in fact, that area is not too bad. There is a little bit of low-grade uptake where the screw came out, but there's actually a hot spot on the lateral malleolus, and this is because this is actually an unfixed fracture, which they missed. So that needed to go back and be fixed surgically. So just to finish off, just to remind you that artifacts can be an issue when we do bone scanning, because the method is very sensitive but not specific. We can see all sorts of artifacts, and the things that can change the distribution of trace are things like bones and urine, and include movement and urinary problems. So we can get things like this. So this patient appears to have 2 heads, and probably what happened is the patient moved their head when they were being scanned. So in summary for our first talk, is that bone scintigraphy is still useful in the age of MRI, and we can look at metabolic issues and a range of bone disease as well as other issues. Pattern recognition of common problems is very useful, and you just get used to seeing them and seeing what's going on, and that just comes with a bit of experience. It's really annoying when you're starting out to be told that experience helps, and it's particularly annoying being told that by old people, but it does. And we can use SpecCT and SpecCT to help us with working out what's going on with these patients. So that's the end of our first talk. So I'm just going to stop sharing, and I'm going to